Good evening and welcome to Doctors on Call. Tonight we're talking about women's health and taking your questions about things like annual exams, abnormal bleeding, osteoporosis, breast cancer, ovarian cancer. So what would you like to know? I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'm your host for our program tonight on women's health. We'll be happy to answer your questions. Just give us a call locally at 218-788-2844 or toll free at 1-877-307-8762. Our panelists this evening are Dr. Gail Baldwin, a family medicine physician with the Twin Ports VA Clinic in Superior, Dr. Melissa Miller, an OB-GYN specialist with St. Luke's Obstetrics and Gynecology Associates in Duluth, and Dr. Nicole Seacotte, an OB-GYN specialist with Essentia Health, Duluth Clinic. Welcome, everyone.
Thank you.
Thank you.
Our medical students answering phones tonight are Whitney Bertram of Belgrade, Minnesota, Carly LaFavor from Grand Marais, Minnesota, and Adam Stroshine of Annandale, Minnesota. And now on to tonight's program about women's health. So it used to be, as a woman, when you came in for your annual physical, the reason you came predominantly was to get a pap smear. We did those yearly. So Dr. Baldwin, maybe we can just start out before we get some questions. Let's talk just a little bit about the change in how frequently we do pap smears.
Well, recently the pap smear frequency for screening has been changed, reflecting some research done that shows that before age 21, most young women don't really need to have a pap smear for screening. After age 21 and between 21 and 30, there's some gray area there, but certainly after 21 and by age 65, those are the main screening ages. And if normal screening happens during that time, you can just do a screening every third year.
Mm-hmm. Can you add anything to
Sure.
that?
We've also added the HPV test, which is the human papilloma virus. It's a virus that causes cervical cancer. It also causes genital warts. It's a very, very common virus, and we find that most women who do have cervical cancer do have that virus. So in patients over the age of 30, oftentimes we do co-testing, which is a pap smear and HPV testing. If they're both negative, women may not need, do not need a pap smear for 5 years. However, they still need to continue with their annual exams. And if it's positive, then we know that those women need to be screened more closely. And we screen them closer based on what their pap smear results are and go from there.
Is there any time or age that we actually say you really don't need a pap smear anymore, Dr. Seacotte?
Some instances, like Dr. Baldwin had mentioned, age 65 or older. The American Society of Colposcopic and Cervical Pathology has recommended that you don't necessarily need a pap smear. Again, it really depends on what your history has been, like Dr. Miller had mentioned. The other thing, if women have a hysterectomy, then some of those women don't necessarily need a pap smear. Again, it depends on why they had the hysterectomy. And I think a lot of times women confuse or associate the pap smear with the pelvic exam, but technically they are different. So like Dr. Miller mentioned, although they don't necessarily need a pap smear, we still are recommending they get a yearly pelvic exam.
And when we're doing that or asking them to have a pelvic exam, what else are we checking for?
A lot of times we will also do the breast screening with the breast exams. A lot of us will do kind of a complete physical for them also. So kind of like a heart exam, lung exam, also focusing on some other issues. Maybe it's depression we're talking about, maybe it's other symptoms like pelvic pain, postmenopausal bleeding, abnormal bleeding like you mentioned. So there's kind of a wide variety of things that we can address during those visits.
How about Dr. Miller? Let's kind of segue just to get some standard things, which are probably a lot of questions that women may have about mammograms too. And the guidelines have changed a little bit about mammograms as well. So can you talk a little bit about that?
Sure, the mammogram guidelines have definitely changed. There are many different organizations that recommend guidelines, and it depends on what organization we look at. I tell patients that we start doing screening mammograms without a family history at the age of 40. However, it is their option to go and do a mammogram at the age of 40 every 1 to 2 years, or they could wait until 50 and start mammogram screening at that time. Women are diagnosed with breast cancer at all ages, and we do have a population of women that do get diagnosed in their 40s, but the screening guidelines are based on actually finding something and the chance of it being a problem versus finding something that results in excessive stress and then having it be benign. So I really leave it up to my patients. If they have a family history, if they have concerns, I recommend screening at the age of 40. I would be interested to see what Dr. Seacotte has to say regarding what you tell your patients, because the guidelines are very much up in the air.
I would agree with you that she's absolutely right that depending on which organization that you are focusing or looking at for your guidelines, they do vary. I know speaking with our radiologists within Essentia, that we have kind of, when the guidelines came out, kind of changing them, they kind of came out and said that still recommending starting at the age of 40, and at that point going every 1 to 2 years, and then after age 50 going yearly. So I agree with Dr. Miller, having those option in that discussion with your patients, again, depends on the family history and personal history, but you know, I've been starting kind of more talking to them starting at their 40s and with the option of going every 1 to 2 years.
Yeah, that's very helpful. Dr. Baldwin, talk a little bit too, and others can jump in about MRIs and breast. When would we potentially do an MRI?
Well,
where that's coming?
I think I'm going to have to defer that question to either Dr. Miller or Dr. Seacotte.
I can answer that question. An MRI is typically done in patients with a strong family history. There are some genetic carriers for breast cancer, meaning that if they have a genetic predisposition, they're at increased risk, and those women undergo MRI screening. And also, I believe it's a 10% lifetime risk that your doctor can calculate for you. Am I correct about 10%?
Yeah, there's a model that you can, based on the personal history and family history, you can kind of click in all that to give them a percentage risk. I think it's important to realize also that MRIs are not only used in and of itself as a screening mechanism. So it's kind of a couple different modalities with the mammogram, and maybe also in addition to doing either ultrasound maybe or an MRI.
Yeah.
So it's
right
not
now
used
we're
in and
not-
of itself.
Yeah, we're not just automatically doing an MRI.
Right.
I think
we're
it's
doing the other
really
tests
important to
first.
know that mammogram is the screening choice. MRIs are used for people who are at higher risk, but women can't just decide they would prefer an MRI because that's not the recommended screening.
Well, Dr. Baldwin, let's switch gears just a little bit because we do have a couple questions coming in. So I have one question about osteoporosis. Actually, I have a couple of them asking about it. What do we recommend for osteoporosis? How would we diagnose this, and then potentially how would we treat it?
Okay. Well, generally for osteoporosis, I usually first try to start with prevention, try to address that with people at ages when they can develop good, strong bones. So normal vitamin D, calcium in their diet, and lots of exercise to keep bones strong in that way. As people, the first year after menopause is when a lot of bone loss occurs, and so you want to do a DEXA scan for people who appear to be at high risk, either by virtue of their own medical conditions or family history. Or if you, for instance, someone suffers a relatively minor injury and say breaks an ankle or breaks a bone that you think, gosh, that's unusual that they would break a bone like that. You would want to do a DEXA scan to look at general bone density and then consider treatment with some of the medications that help to improve bone density at that point.
Very helpful. So I have a caller, Dr. Miller. This is a caller from Duluth asking about after having a hysterectomy, why do we continue to have pelvic exams completed? So she's not saying if she had her ovaries removed or not.
Sure. When we do a hysterectomy, almost always we take the uterus and the cervix, but we may leave the fallopian tubes or the ovaries, or just leave the ovaries. So the pelvic exam is actually an evaluation of the ovaries. And it's also important on pelvic exam to look at the vulva, which is, the external genitalia, because people also get vulvar cancers. So even though we've done a hysterectomy, it doesn't mean that we have removed all the female organs. There are still female organs that do need to be examined. And even if you've had a hysterectomy where the ovaries have also been removed, the vulva should still be examined at least once a year.
Excellent, very helpful. Dr. Seacotte, this is a caller asking about CA125, for ovarian cancers. So when are those tests ordered? Do you need more risk factors in order to have those tests ordered?
I would, there's no good guideline to guide us of when to order necessarily, but I would order it if I have a woman, especially a postmenopausal woman, that for whatever reason we did some imaging, especially an ultrasound, and they have some, like an ovarian cyst that appears more complex in nature, and depending on size also. And so in those women, I would order a CA125. Now if I have a young woman who's still getting her periods, and we, for whatever reason, did an ultrasound and they have a cyst, many times those cysts are what I would call physiologic, and they'll come and go. And so a lot of times a CA125 is not necessarily indicated. And a lot of times we'll follow that with a follow-up ultrasound in 6 to 8 weeks to make sure that there's some resolution. But it depends on the appearance of a cyst on an ovary. It's important to note that a CA125 is not specific for ovarian cancer. It is a very non-specific test. It can be elevated for multiple reasons, including liver disease, kidney disease, and many other factors. And so it's not specific for ovarian cancer. Also, with that said, some women may have ovarian cancer and the test can actually be negative. So I'd really base it on the individual patient and their imaging results.
Very helpful. Dr. Baldwin, we're going to go back to osteoporosis just for one more question here. It's a caller asking about treated for H. pylori. So there's some news, I think, out about proton pump inhibitors and potentially osteoporosis issues. Is there any potential time period or any conversation we want to have about this particular question?
Well, I think it's come up with magnesium and I presume calcium, as it's a similar ion, aren't absorbed as well when people are on proton pump inhibitors. And when proton pump inhibitors were originally released, the recommendation was for very short periods of time to be on these medications that drastically reduce acid production. And now we see people that are on proton pump inhibitors for years and years and years and suffer reduced absorption of certain things. Anything that requires acid for absorption isn't going to be absorbed as well. So B12 might be one of those things that would have problematic absorption. And thus, that would be the reason that someone who'd been on a proton pump inhibitor for so long might not have good bone health, because even if they're taking extra calcium, they may not be getting enough absorption.
Very helpful. It's an interesting question, Dr. Miller, about someone with a strong family history of uterine and ovarian cancers and with subsequent deaths early. And they're wondering, is there a place for prophylactic hysterectomies? It's probably a good question.
Yep, that's an excellent question. There is a place for prophylactic hysterectomies and removal of the ovaries and fallopian tubes. Those patients, I do recommend undergoing genetic testing first to see if they are carriers, to see what increased risk they are, because ovarian function is actually very important. It helps decrease the risk of cardiovascular disease, such as heart attacks, as well as osteoporosis. So we wouldn't do a hysterectomy and remove the fallopian tubes and ovaries unless, for a patient with the concern of being at increased risk of ovarian cancer, unless she's genetically proved to be at risk. So So she would need to undergo genetic
Genetic
counseling and testing prior to proceeding with that procedure.
And I think the other benefit of getting genetic testing done is that there's, besides just ovarian cancer, there's other risk factors that they should be aware of, and how should they move forward with that, such as if they're what's called BRCA positive, which is a gene mutation that some women can have, what puts them at risk of breast and ovarian cancer. There's also what's called Lynch syndrome, which puts them at risk of endometrial uterine cancer, but also colon cancer. So there's, many other things to kind of look at, and reasons for having the genetic testing done.
Yeah, it is a complicated concern for people. So, Dr. Baldwin, a question about uterine prolapse, and potentially a conversation a little bit about pessaries if you weren't surgically able to have a correction. Can you talk a little bit about that?
Well, pessaries are devices that you insert into the vagina to help hold the uterus in a more anatomical position, and can be helpful for people who are not surgical candidates.
And pretty commonly used as people age and have more problems. Go ahead.
I guess I would just like to add, because a lot of people don't really understand what pelvic prolapse is. Pelvic prolapse is when the bladder will shift down into the vagina, and the rectum can shift up into the vagina, and the cervix and uterus can fall down. It causes pelvic pressure, sometimes causes difficulty emptying the bladder. Sometimes people have pain. And if people have symptoms, I typically tell people they have 3 choices. One would be to do nothing because it's not life-threatening. But the other is a pessary, which is a device that's inserted inside the vagina to help hold everything up. And then the third option is surgical. It's very common. Many people suffer from pelvic prolapse.
I think a lot of women don't actually talk about it.
Right.
But the other thing I think before, kind of prophylactically, is women being educated and learning about their Kegel exercises. So when you have, starting with when they're pregnant or after they deliver, kind of really focusing on their pelvic muscles, which is not really intuitive for us to think about, but we do have pelvic muscles that help support our vagina and the tissue around it. And so working on those muscles, just like any other muscle, is only going to strengthen them. And so there are ways to do that, and also there are physical therapists that will help a woman focus on those muscles and learning how to contract them and exercise them, so that hopefully that'll prevent any progression to the point of where you're needing a pessary, or maybe you're needing surgery.
Is it related to having more children? The more children you have, potentially, that you might have more problems with prolapse, Dr. Miller?
Well, the risks of pelvic prolapse are having vaginal deliveries, or having labor and then needing a C-section after progressing through labor, obesity, smoking, heavy lifting, sometimes just genetic. Some people don't have the same genetic strength in their pelvis as others and are at higher risk if their mother or their grandmother have also had pelvic prolapse.
Well, very helpful. Well, Dr. Baldwin, let's switch gears a little bit here again too. Let's talk about aspirin. I have a caller asking about aspirin as a woman. Should we take 81 milligrams of aspirin? This usually raises some controversy here. But
That is the question. We know that it can be very helpful for men, but I think the research isn't quite as strong for use of aspirin just in general for women, at least the last I read.
or maybe if there is a history of a recent heart attack or something like that.
Oh yes, I thought you meant as a preventative, but yeah, you might want to use it if you had a heart attack or a reason to use something for decreasing the risk of developing a clot.
And Dr. Seacotte, a caller asking about abnormal bleeding. When do you go to when should you see your doctor if you're having some abnormal bleeding?
I think it really depends on your age and medications. I would just, I would say for any woman who's gone through menopause, which is no periods for a year, and they have some degree of bleeding, whether it's brown, pink, bright red, if it's just spotting, kind of light, heavy, any degree, I would recommend that they should be seen by their doctor. Many times this is a benign thing, but I think it's important to be evaluated. For younger women who are still getting their periods, are they on certain birth control that increases that risk, such as some IUDs? Some women will be more prone to spotting at times that might be a little bit more irregular than what they're used to. Sometimes starting off on birth control, such as the pills or the patch or the NuvaRing, including any form of birth control, whether it's the Depo shot or the Nexplanon, can increase your risk of at times of irregular bleeding. I think it's important for young women who've gotten their periods but then are skipping their periods for a prolonged amount of time. If they're going 2, 3 months, 6 months, a year, that is not normal, and that needs to be evaluated. So I think it really depends on what else is going on.
And I'm just going to interject. If they're on birth control pills, because a lot of people will ask about that, it is okay to skip and not have a period for 3 months or even a year. But that's because the estrogen and the progesterone in the birth control are perfectly balanced, resulting in a woman not getting bleeding. Dr. Seacotte is talking about people who spontaneously, not on hormones, all of a sudden stop getting their period. That needs to be evaluated.
Absolutely.
Because that puts people at increased risk for endometrial cancer.
Right.
And then the other thing I wanted to stress is that with postmenopausal bleeding, like Dr. Seacotte talked about, whatever the bleeding is, they should come in for evaluation, because there have been studies that look at whether if it's just spotting versus heavy bleeding, is there a better chance of having cancer? And they found that any bleeding, it doesn't matter if it's a little bit or a lot, people are at risk of endometrial cancer, and everybody needs to be evaluated.
Right.
So I would want the public to know that. If you're having postmenopausal bleeding, you need to be seen.
Absolutely.
Yes,
You
absolutely.
do not want to ignore that.
Well, and then Dr. Baldwin, a little conversation about menopause and symptoms, and then medications that we might place someone on if they were having menopausal symptoms.
Okay.
That seems to be lots of questions about that.
The menopausal symptoms are commonly, everybody thinks about hot flashes, and sometimes hot flashes result in loss of sleep and some mood changes that can happen at the same time. To address the potential for medication use, we use hormones. In my old days, Premarin was one, but we use various hormones. There are more than just that one available these days to help reduce hot flashes and the vasomotor instability that can come with menopause and hormone changes. We do no longer try to keep women on those hormones forever, and we no longer say that they are helpful for preventing cardiac risk, but they can certainly be very helpful at restoring a little bit of normalcy in a life when a woman's being so troubled by hot flashes that life is really getting out of hand.
I think it's important too that women who still have a uterus, so meaning they have not had a hysterectomy, they need not only estrogen but also progesterone, because like the birth control pills, it's a balancing act, and so they do need both of them. For women who have had a hysterectomy, they can use estrogen alone. But there are other things besides hormones that women can utilize to help with some of their vasomotor symptoms. But that's just kind of an example.
If they are having abnormal bleeding, Dr. Miller, talk to us about, we do a biopsy? What happens when someone comes in with a problem with abnormal bleeding?
Well,
postmenopausal.
Well, the first thing I want to mention is almost always the abnormal bleeding is not cancer. So, that just to put people's mind at ease. But it's very important to rule out cancer, because if cancer of the uterus is caught early, it's very curable. So it depends on what the history of what's going on. But typically we like to order an ultrasound to make sure that there's no polyp, but also do a biopsy of the lining of the uterus if the ultrasound shows a thickened uterine lining, because that does put people at higher risk of the concern of cancer. So typically an ultrasound and a biopsy is what I would do.
Would we ever do a blood count just to check as far as anemia, Dr. Baldwin?
Well, certainly if somebody has been experiencing bleeding just about of any type, whether that's vaginal bleeding or rectal bleeding, it's nice to do a blood count. And You might check platelets too, just to see if that's part of the problem, but yeah, a blood count would be good.
Good. Well, thank you. Our time is over already. It goes really fast. So I want to thank our panelists, Dr. Gail Baldwin, Dr. Melissa Miller, and Dr. Nicole Seacotte, and our medical students, Whitney Bertram, Carly LaFavor, and Adam Stroshine. Please join Dr. Ray Christensen for a program next week on men's health. His panelists will be Dr. Nathan Hoffman, Dr. David Hutchinson, and Dr. Andrew Nisbet. Thank you for watching. Good night.